The presentation really started with just talking about one of our patients. His name is Cliff, and Cliff had colon cancer, stage 3 colon cancer. And by the time he came to rehabilitation, and my clinical training is as an occupational therapist, so I've been working in cancer rehabilitation for just about 20 years, and most recently I've started focusing on just how can we improve the quality of the cancer rehabilitation we're providing. And so Cliff, going back to them, he had colorectal cancer and was complaining of just not feeling like himself. And he was also complaining that he felt like he was walking with moon boots, if you can remember. So like, it reminds me of, you know, being a kid walking in moon boots and not being able to really feel your feet. But it made him really worried about going out into new places that he felt really uncomfortable. And so when I think about what we can do for cancer in cancer rehabilitation and for patients, especially patients like Cliff, I think about and described in my session how I look at I use the World Health Organization model of the International Classification of Function and Health and Disability. And in the model, it talks about function as being, and how people function as being varied and quite, you know, from simple to complex. And so when I think about Cliff, I think about his health condition, which is, of course, he has cancer, but he also happens to have diabetes for many years, and he has macular degeneration and arthritis in his knees. And so that all kind of comes together at a head through his cancer treatment and diagnosis. And then I think about, well, how does that health condition really impact his body systems and functions, so like the musculoskeletal system, those sorts of things, when he's moving around doing the things he really enjoys to do. And then I think about, as an occupational therapist, I also think about activities, so being able to physically dress himself, to taking care of grandchildren and doing things that and what we would consider IADLs, vacuuming, housework, that sort of thing. And then I spoke a lot about the differences between a specific activity and really engaging in participation, and showed a few photos of older adults. One of them was actually a photo of my father playing softball. He's 75. And one was an older gentleman in his 70s rock climbing, and one was a woman taking care of her grandchild. And it's the point I was trying to make is that participation is quite complex. It's not just how we're functioning. It's this multifaceted experience of engagement in life that has to do with the environment we're in, really the situation that we're brought up in, and where we're at. And so when I think about cancer rehab and I think about this patient, Cliff, I think about those sorts of things. So Cliff was not only having difficulty walking because he couldn't feel his feet very well, but he was having difficulty. His hands felt very numb from the peripheral neuropathy from the chemotherapy. And he was having difficulty buttoning shirts and zippering his pants, but also working with tools, woodworking, yard work, that sort of thing. And so we worked together as a team, the physical therapist and the occupational therapist, to come together to really help him be able to do those things again. And so when he spoke to his oncologist, it was mostly, you know, he says, I'm doing really well, I'm feeling fine. But when you really were able to sit down, and one of the unique things about being a therapist is the amount of time we get to spend with somebody. So we got to really figure out what was going on with him, and then be able to really help him re-engage in life. So in a nutshell, I think about the geriatric assessment, which is talked about a lot in this conference, and how when we're measuring the geriatric assessment, it is a step from a performance assessment that was done as the oncologist. It's much more in depth. We look at function, but we look at function still quite narrowly in terms of activities of daily living and instrumental activities of daily living. And I was challenging the audience to really think about it in a full engagement in life kind of perspective, and really that the interventions that we provide can really help patients return to that. I got feedback from a gentleman in India, who lives in India, who was pointing out essentially that in his culture, the older adults live with their family members. And so he was thinking, would the outcomes of rehabilitation be different if someone had more of social support at home? And we don't have any, hard evidence yet to say so, other than preliminary studies and other studies that have shown that which is what we would assume, that the more social support you have, the better off you do through cancer, and also within being able to function, et cetera, depending, of course, on the type of cancer and that sort of thing. But having support at home definitely puts you a step ahead, for sure. One of the things I love about this meeting is that the people here are very open to new ideas and expanding their perception and their perspective. And in oncology, a lot of the times, in general oncology, I think the outcome that patients and people and docs were really concerned about was survival. And I think in geriatric oncology, it's really recognized that being able to engage in life and quality of life in itself is really important. I think that I was invited to talk, and what I'm hoping people take away is that it's much more, we have a lot more that we can offer, and I feel like we're really at an exciting time where we're just starting to scratch the surface of what we can really help people with and get them back to living well during and beyond cancer. The only other question I was asked by a participant was about driving in particular. Driving can be quite distressing if you're unable to drive anymore. And so I just wanted to mention that when I responded to him, I said there, at least in the States, and I'm sure in other countries, although I don't know for sure, the occupational therapist can do driving evaluations. And it can either be in a simulated setting, and some therapists specialize in driving and get behind the wheel with people and that sort of thing. So it varies, of course, by clinic, but that is definitely something we also help patients get back to doing.